All right, it's a long one. I'm going to get started. So I think, wow, 99 might have been the first version of this paper. And then 2007 was kind of like a mainstream one that got a lot of notoriety. And then 2014 was the last one. It's normally every 5 to 7 years. The COVID happened and everything. So 14 to 25 is quite some time. So it's a lot of organizations, but it's generally known as the ACC and the AHA guideline for the cardiac patient for non-cardiac surgery. And there is nothing more useful than this on your pre-ops, right? I mean, it's right in front of you, it's an algorithm. But remember, it's a practice guideline. So if something's not right with the patient that is congruent with the algorithm, doesn't mean the case is canceled. It means you have to use some judgment. And practice guidelines are basically an algorithm for you to follow, but you can always supersede it with your sound clinical judgment. All right, so every slide will have next to it a class of recommendations. So just to review, you have 1, which is everybody pretty much agrees it's what you should be doing for the care of your patient. 2A is there's some pretty good evidence for it in favor of it. 2B is it's thought to be useful, but maybe not as strong as 2A. And 3 is maybe you should not do that intervention, or maybe it causes harm. So either no benefit or harm. And then beyond that, when you look at a specific intervention, like take beta blockers or whatever, they'll talk about levels of evidence, and that can be A, B, and C. A is multiple, randomized, prospective, controlled trials. B is data derived from either one good trial or multiple non-randomized trials. And C is more of a consensus of experts, which all hold some value. All right. So I think everyone's familiar with the last version. This version's quite different. So those red circles are like the 4 buckets of things that you look at when evaluating a patient. We have patient factors like functional status. Functional status is, can you get past 4 METs? So 4 to 10 METs is, everyone in here is exerting 1 MET sitting here, consuming oxygen, 3 mLs per kilo per minute of oxygen you're consuming to stay aerobic. And if you walk up to brush your teeth, maybe you push that to 2 METs. But if you can do 2 flights of stairs, you're past 4 METs. And once you're at 4 METs, there's 2B evidence that predicts that when you're getting stressed during surgery, which, let's be honest, when patients are under surgery, it's basically a stress test. Whether it's being a little dry, your contractility's up, your heart rate is up, the number 1 determinant of MVO2. You're shivering, using more myocardial oxygen consumption. You're bleeding, you have less O2 content, you have all these pro-inflammatory cytokines. It's all stress. So if you can exert yourself on the golf course, if you can walk 18 holes of golf carrying a bag, you're maybe closer to 10 METs without getting chest pain, shoulder pain, jaw pain, shortness of breath. That means that your body's able to deliver enough oxygen to prevent ischemic symptoms. And if you can find that the patient can do that without symptoms, they probably can tolerate a fracture case where they're going to have surgical stress. So functional status is a surrogate for us to say that the patient can tolerate the stress of surgery. And like I was saying, 4 METs is like 2B, and closer to 10 METs is 2A evidence. So obviously if you can tease out that they can do more, that's a good thing. But 4 METs is generally 2 flights of stairs. You might have a patient who can walk 7 city blocks every day to work. Like, that's a good way to tease out what they can do. Because not everyone goes to the gym and works out, and can tell you that piece. There's a new piece here called frailty. And that wasn't really looked at in the last algorithm. So we'll talk more about that. There's our risk calculators, which I'm going to go through. basically NSQIP and RCRI. Surgical factors are like, if it's an emergency volvulus, it's a different risk category than an elective case. So that's one piece of that, and how big of the case it is. For example, it'll show you in the next slide or that breast surgery is low risk, but that Chalfoun case that went the other day, that was like 12 hours with the tram flap. It's a breast case, but it's not low risk. So those are surgical factors. And then brand new to 2024. So this was September of 2024 that this came out. They added cardiac biomarkers. And basically, they've gotten much better at looking at myocardial injury and using biomarkers to determine if there's underlying disease. Just under this risk calculator thing. So Goldman was like, I guess the 70s, Goldman and Deskys, they were risk predictors. And then the RCRI is 99, but it's still really valid. And then the NSQIP is I'm going to talk about is even more recent. All right, so when you look at functional capacity, I just kind of went over it. You could do this quick and dirty. Can you do 2 flights of stairs? Meaning if you have to go up the first flight and then stop and put your hands on your knees, that's not able to do it. You might be able to get to the second flight, but you're trying to tease out symptoms. And then there's this Duke Activity Status Index, a DASI, and that is more accurate than just asking someone if they can do 2 flights. So if you ever want to dive deeper into a patient, you can run them through that whole scale. But in general, we're gonna try to figure out, if they can do this 2 flights kind of thing. Now the frailty is, I did a total shoulder yesterday, and she walked in the holding area with a cane. That's a different patient than someone who just walked in from the pickleball court, right? So they're saying that 10%, 1 in 10 patients over 65 in the community are frail, and this is going to pose higher surgical risk. So they want us to recognize that, which maybe wasn't in the last guideline. All right, and our ultimate goal, and you'll hear this term throughout the lecture, is to prevent MACE. So we're trying to predict who's going to have MACE. We're trying to prevent MACE. And what MACE is perioperatively, there's either an MI, stroke, hospitalization because of heart failure, and that's one we may not recognize often because it happens maybe a couple of days later. Maybe we don't hear about it. Maybe it's subtle. The patient turns up being fluid overloaded and has some sort of poor outcome at some level, but that's part of MACE. Needing to be revascularized or PCI or going for open heart. So that's MACE. And this is probably my favorite, most important eye-opening thing in the whole guideline, is that we are always talking about CAD. This guideline is really getting away from that. It's still important, but they're realizing that based on this cohort, the risk in a CAD patient in 38,000 patients, 30-day mortality was 2.9%, but in the heart failure patient, it was 1 in 10 patients. And so I think we have to put more focus on the heart failure and the AFib patient than the CAD patient. And there's a real push away from stress testing. There have been millions of stress tests since the 2014 guideline, and they're not so sure it really improved outcome. So that's big news. All right, and just to go a little deeper there. So when you see a number like 1.2%, you say do really 1 in 100 patients have an event, die? No, but in this cohort, that's what happened. So maybe it was at a high-risk center with high-risk surgery and high-risk patients. But anyway, you can compare the different groups. So preserved ejection fraction, we're seeing this a lot in the charts lately, quite a bit different. So even though the EF is normal, see the echo, EF's normal, go to the OR, don't worry about it. Even though the EF's normal, there's quite a bit more risk there, like almost 4 or 5-fold. And then, it's really this number that should get our attention to talk to the surgeon and say, is this the right intervention for that patient? This patient wants a total knee, this patient wants a total shoulder, their EF's 29 or less. You can talk about these kind of numbers. It's a 1 in 12 chance that they could die. And again, that's a very big number. I'm not saying that that's necessarily the case in that shoulder patient, but really, you could say there's 8 times the risk, versus someone without heart failure. I think that's valuable. And the surgeons don't want a problem. They don't want their patients to have a problem. You think we have to deal with a problem? They really do for months and months and months when there's a poor outcome. So sometimes when you spell it out like that, it can help you either get them into a less invasive procedure. Maybe there's another alternative, or maybe not even do that intervention. And then just to point out, they talk about if there is an MI that really, after 60 days, mortality doesn't drop too much more, but going from 30 to 60, 0 to 30, and then 30 to 60, there's a benefit to wait. So that the guideline still has that. Give it 2 months after an MI at least. And if you got a stent in the setting of an MI, they want you to be on dual antiplatelet therapy for 12 months. So I think that's important for your oral boards and for real life is that, after 6 months, you can stop dual antiplatelet therapy. And even after 3 months, if the benefits outweigh the risk, meaning like you don't want to wait 6 months because they need surgery for cancer or something, you can consider stopping the Plavix. But in the setting of PCI after ACS, dual antiplatelet therapy is really for a year. And again, this is always going to be a decision with the cardiologist and the patient, and you're going to talk about it with them because there's a lot of things you don't know about their intervention that maybe the cardiologist does. All right, so this was 07. In 07, there was like low, intermediate, and high risk. They got rid of intermediate. I just want to point that out. It's either no elevated risk or elevated risk. That is now the 2 categories, and it's greater than 1% risk of MACE is elevated risk. And this was 14. You can see it was something we've gone over a lot. You do a risk prediction tool, and then you look at exercise tolerance, and those are the 2 things. But now we have this one. And I'll tell you what, it's a lot harder to teach because it's a lot more, there's a lot more weeds here. But I think overall, it prevents you from missing certain things. Like, for example, if a patient had a flow repair in the old guideline, it didn't account for it. Their RCRI could be 0. And their exercise tolerance may be 4 meds because they could do 2 flights of stairs and they would go right through. Same thing with severe pulmonary hypertension, severe valvular disease. They weren't accounted for. So in this new guideline, we added risk modifiers.
I understand you have a bad day, you don't have to bring it. Dude, there's no bad day. Just stop talking.
Should I stop talking? Okay. So we have our guideline. I'm going to go through step by step. All right, so I'm going to talk about in the next slide types of surgery. But I want to point out what they consider to be elevated risk non-cardiac surgery is intermediate and high. All right, so this guideline applies to elevated risk non-cardiac surgery. So if it's a low risk surgery, you really don't have to go through it as much. It's really, you want to make sure that patients who are going for elevated risk non-cardiac surgery, and that's anybody here. Now you might say, is a McGinnis finger case the same as Hemi? No. And so you can use a little judgment and you can get ortho into the low risk category, and you can get a breast case into that intermediate risk category like I talked about before. But in general, like endocrine, if you have an all-day thyroid, that's not low risk. But if it's a good surgeon and a 1-hour parathyroid, that is low risk. So we have our urgencies, which I have a whole slide for, and then our types of surgery are either not elevated risk non-cardiac surgery or elevated risk non-cardiac surgery. And our risk of MACE is either low or high. So emergent is in the ER and there's blood in the belly. It's going to the OR. It's volvulus bowel, necrotic bowel. It's dissection of a vessel, right? These are going to the OR. So those are your emergencies. Your urgents are, the example I like to use is someone with potassium of 7 who has a compound fracture. It has to get to the OR, but you could dialyze them first, you know, so that's more urgent. Then time sensitive would be, you know, you're not going to wait a year, but you can certainly get them to the cath lab and manage them for a week, whatever it is. You have a patient with unstable angina who needs breast surgery, it can wait. And then you have elective, which is, you know, patient with critical AS, who's symptomatic, who needs a total knee. It can wait. We can go fix that valve and bring them back, which we've done here multiple times. All right, so I'm gonna go through the algorithm top to bottom. So you have a patient with cardiovascular risk factors. So if you've got your 18-year-old ACL with no history, this is not for you. This is not for them. This algorithm is for patients with cardiovascular risk factors, disease, or symptoms. First question, is it an emergency surgery? So that patient with the dissecting aorta is going to the OR. So if it's emergency surgery, you go to the OR. Now, doesn't mean they're going to live. I'm not telling you that like, oh, I followed the algorithm, what happened? It means they're going to proceed at higher risk. Have the appropriate risk-benefit discussion with the family. You have to do the appropriate level of monitoring, whether it's, you know, TE or A-line, or maybe you'll more aggressively react to low blood pressures, or vasopressors, you go to ICU post-op. But if it's an emergency, we're going to proceed. If it's not an emergency, you're going to ask, are they in one of these decompensated positions? And if they are, you're going to treat it as if they were in the ER and they didn't need surgery. So if someone is in uncompensated heart failure, so Benoit patient comes down, AV fistula, they're an inpatient, and you look at them and they're in decompensated heart failure, you should not proceed. You should not proceed. You should get cardiology involved. You should say, this patient's decompensated, can you tune them up? And then bring them back when they're tuned up. Unless cardiology says this is the best they will ever be, and we feel that giving them this fistula is better than them having a permacath for the next 4 years, then you may proceed at a higher risk. But if they have unstable angina, they have AFib with RVR, they have decompensated heart failure, you're gonna do GDMP, goal-directed medical therapy. So that's the same treatment they would get if they weren't for surgery. All right, so if they present with risk factors, it's not an emergency, they don't have decompensated position, you're then going to come here. And this is the old part, which it still has. You're going to evaluate RCRI or NSQIP, which I'm about to explain. And you're also going to look, do they have a risk modifier? So this is new. So you are on the floor doing your pre-op tonight, and you determine their risk, are they elevated risk of MACE or not, greater than 1% or not, and do they have any of these? And I'll tell you what to do with that. All right, so yes, it's evidence-based to use a risk tool. These are the two tools. The first tool is called RCRI. Everyone heard of it? So the Revised Cardiac Risk Index. In 1999, Thomas Lee published this in Circulation, and it turned out to be very well validated. But it has some flaws. It's from one hospital. It's not a multi-center look at patients. It's from one hospital in Massachusetts. It's 4,000 patients. And so it may not apply to what we do here. But the correlation coefficient was close to 1, and it was determined that if you have these risk factors, you are at increased risk, and it's stuck around. But I want you to keep in your mind that it's 26 years old, and it's from one hospital, which is one set of surgeons, one set of anesthesiologists, and it may not apply to what happens at like East Orange Medical Center. Okay?
So
Yes, sir.
The same Dr. Goldman who worked on the original senior author.
I would assume SL. Yeah.
Good.
Yeah.
Where do you see Goldman?
Oh, right there. Yeah. Oh, right. Yep. He's the last name listed. I guess they did him a favor there. Yeah. All right, so what is RCRI? You're looking at, do they have history of CAD, CDA, CHF, diabetes with insulin, or creatinine over 2? And then you look at the type of surgery, because suprainguinal vascular, intraperitoneal, intrathoracic, those are higher risk than low risk. So that's their version of, is it intermediate or high risk surgery? And if they have more than one of these, meaning 2 or greater, they're at elevated risk of MACE. So that looking at risk modifiers, if someone has history of CHF and creatinine over 2, they're at elevated risk of MACE, and that was that little yellow box there. And that's predicting MACE, which I told you what that is. All right, you can do it online, but obviously you don't need to. And the second tool is the NSQIP. What this is 1 million US cases were looked at based on ICD-10 codes and diagnoses, and so they were able to pick up like NSTMI and stuff like that better looked in that one hospital, looking at 4,000 cases. This looked all over the country, 525 hospitals or whatever it was, and it takes into account more than just those 6 things. So how this works is you have a patient in front of you, and they're like, I really want to talk to you about my anesthetic risk, or my mom's risk. She wants to have her shoulder done, and I don't think it's a good idea. So you can go to the website for free, punch in everything, albumin, exercise tolerance, age, the code for the type of surgery, which is a big thing here, because it's like the lumpectomy is not your mastectomy, is not your tram flap. So you can punch in the type of surgery, and then it will give you a printout of their risk of wound infection, their risk of pneumonia, and their risk of MICA, which is their version of MACE, MI cardiac arrest. So if that's greater than 1%, that's your MACE, your elevated risk there. And so this is what it looks like. So look at these factors. These are what are evidence-based to predict outcome, right? Because there's a lot of stuff in the chart, but these are the things that they came up with that said, hey, this matters. You can see it's much more in depth than RCRI, but when you got 7 pre-ops, you're doing the RCRI. But if you have that patient in front of you and they want like a really detailed response, then you do the endoscopy. I've done it 3-4 times, usually to show a surgeon that I don't think it's the right thing for the patient. This is kind of the printout it gives you. If we could teach our PAT nurses to use this, I think it could be a good tool for them when they're talking to patients. All right, so once again, patient has risk factors. It's not an emergency. They're not decompensated. And then it looks at these 2 things. So the next screen is this one. And this is one where I was like, ooh, this is going to be hard to teach because it's just a little overwhelming at first. But the bottom line is, if they have a risk modifier, no matter what the calculated risk is, they want you to go through here first. All right, so this is new. So if they have critical AS, they have severe pulmonary hypertension, elevated risk congenital heart disease, there's a slide for that later, but it means like not like a ASD repair when they were a kid and the heart's normal. It's like a Blaylock shook or something, you know, it's like they're not back to normal. If they have a pacemaker or AICD, if they have PCI, which is a lot of patients, they're gonna go along this pathway here. So what does this pathway say? I don't know, it's pretty much common sense. It's pretty much common sense that you would do a team-based consultation to determine the timing of this non-cardiac surgery and discuss options for testing and management. And you're going to look at the EKG. You're going to consider an echo if someone's short of breath and you don't know why, and they're going for elevated risk non-cardiac surgery, right? So that's not endos. So colonoscopy is not elevated risk non-cardiac surgery. But if they're going for elevated risk non-cardiac surgery, which again doesn't even apply to like a lumpectomy, we're talking about those 2 columns that I showed you. Then you would say, oh, I don't know why you're short of breath. I should check your echo. Or I hear like a crescendo, decrescendo, 4 out of 6 murmur at the right sternal border radiating to the carotids and subclavians. I should get an echo. You had moderate AS 5 years ago on the echo. Maybe I should get an echo, right? And so if you have a risk modifier and you're in that area and you're like, I need an echo, then get an echo. But remember, it's for an elevated risk noncardiac surgery, which is not a cataract. It's not even, I'm using that lumpectomy a lot because it's like a general anesthesia case, but it's low risk. And so cystos apply to that. Maybe like a quick ankle fracture versus like a prone buy now that's going to be 5 hours with maybe a surgeon who's slow. Those are different situations than something like a Callahan ankle, which is like, 45 minutes. Now, they added this a lot. They don't want patients getting lost. Like, we just recognize there's a problem and we don't want to just move on. We want to make sure they get put on a statin and a beta blocker and an ACE or whatever. And so that's not for us to do, but it's for us to plug them into the system. So if we recognize that someone is elevated risk patient, they should get goal-directed medical therapy. All right, so I'm going to kind of go through each one of these one by one if time permits, but this is basically saying take a team approach. Pick up the phone, call their admitting doctor, and discuss, hey, this patient's for OR. They had PCI 6 months ago. Can we talk about if they're ready to go to the OR? All right, so once you get through that team-based approach, you look at their exercise tolerance. And if they don't have poor exercise tolerance, you're going to the OR, right? So they're patients with an elevated risk. So this side was if their risk modifier, no matter what their risk predictor tool was, but now this side is they do have elevated risk of MACE. So you have your patient with history of creatinine over 2 and diabetes with insulin, so they're elevated risk of MACE based on RCRI. You look at their EKG, you don't see anything crazy. You make sure they don't get lost to follow-up. If they can walk those 18 holes of golf, you're going to the OR, even with elevated risk of MACE. So no longer, you're not like, oh, I need an echo stress test because this is an elevated risk case and they have elevated risk of MACE. No, if their exercise tolerance is good, it's reasonable to go to the OR. Now, if their exercise tolerance is poor, so you have a patient with either a risk modifier or elevated risk of MACE, and they can't exert themselves. So that's my lady yesterday, the total shoulder, who walked in with cane. And she had some elevated risk of MACE. You would think, oh, let's go do the echo and the stress test now, but that's changed now. So now they're going to talk about biomarkers. So if I'm obese and I can't do 2 flights of stairs, it may be because of deconditioning. It may not be because I have a bad heart. And so one way to screen for a bad heart is to check biomarkers. So if I check a BNP on myself and it's 40, I don't have LV dysfunction. It's very specific. So I got elevated risk of MACE, I have poor exercise tolerance, and a normal BNP is probably not cardiac problem, and we can proceed. It's reasonable to proceed. So that's new. That's a new way to look at things. And it's a way, in the past, it was hard to say, like, I know this obese person doesn't have a bad heart. They're like 38 years old. They're just out of shape. So a BNP is a way to say that, oh, the heart's fine. And troponin along the same lines, but look, 2A versus 2B. All right, so if you got elevated risk of MACE, poor exercise tolerance, BNP is normal, proceed to surgery. But again, this is a practice guideline. It's not a standard of care. It means you have to look at the patient, you have to make decisions, you have to make sure it applies to the situation. Now, if their BNP is high or their troponin's high, and this happened to me recently, ankle fracture, lady had never been to the doctor in like 50 years. She was probably in her 70s. She looked terrible. Her pressure in the holding area was 190 over 110. It was O'Keefe ankle. Her troponin, someone checked the troponin, it was elevated. And by elevated, they mean greater than the 99th percentile of normal. So that's her lab work telling me that there's heart disease underneath it all. And on top of that, her pressure's terrible and it's gonna be a longer case. And so I postponed that to get her pressure under control. Versus troponin, proBNP in the chart are normal. She's a little bit younger, looks a little bit better. Her pressure's elevated, but I see maybe a normal one in the primary care office or something. They're two different patients. And so it helped me risk stratify and delay that case, which normally I may have brought in. So
So are you like basically doing outreach practices with elevated risk?
no, I'm trying to teach you guys how to determine like what's in the chart and use what's there. And if you see BNPs ordered by the cardiologist, you'll know what to do with it now. And maybe you'll suggest it in certain situations. This is not mainstream yet. It's mainstream in the fact that it's in here, but I think they're still working it out. What's up?
To piggyback that,
Yeah.
did you say that biomarkers are mostly used for screen to avoid excess hypertension?
100%. That was our whole, because I've, besides, reading it, I've watched a few of the people on the panel talk about this. And their underlying point is like, don't overtest. Don't overtest. Don't overtest. It's not making a difference. It's not improving outcome.
You say your diet, elevator right there, and now it's like they're 40 BMI, I don't know if they're all you say. It's like
BNP is normal, it's not LV dysfunction.
yeah,
Yeah, and where did I say all the risk is from? Heart failure.
yeah.
And so if the BNP is normal and they don't have heart failure, that's a big chunk of those patients. I'm not canceling,
Yeah, no, I get what you're saying.
Yeah, I'm trying to prevent the cancers.
If we interpret it
yeah.
wrong as
Right, and okay, so let's say it is elevated, because that's kind of what you're saying, so it is abnormal. Then you decide, is more workup gonna help me? If I'm doing a gamma nail, the patient's not decompensated in front of me, and the BNP is elevated, I do an exam, I don't see pitting edema, ABB, patient's breathing okay, lying flat. I'm going to proceed because them laying in bed for 48 more hours so I can read an echo is not going to help them. It's going to hurt them. And I might treat them a little more delicately though. I may watch them a little closer. And so that's a piece of it. But if you do think the workup is going to help you, then we do the workup. So abnormal biomarkers, talk to the team, and maybe pursue a workup or defer and proceed with surgery or do something else. Fair enough? All right, so what is proBNP? ProBNP is before it gets hydrolyzed into BNP and it sticks around longer. So you could check BNP. What is BNP? Its atrial stretch leads to the release of brain natriuretic peptide to help your body deal with the extra fluid and be diuretic. So proBNP sticks around for a week. So if I have a bad heart and I like drink like a fish over the weekend and eat like salty food and I get a little heart failure, but I test myself on Friday, I may be back to normal on my BNP, but my proBNP will still be elevated. So proBNP is going to be more sensitive for LV dysfunction. And this vision trial looked at proBNP and risk, and they said if it's over 100, you're elevated risk after surgery, but if it's over 300, you're very high risk. So proBNP of 300, I think is what this paper is using, but anything over 100 is elevated. And then for BNP, over 92 is elevated. I don't know, anyone knows what they ordered here? I think pro, right? I'm not too sure. I know it's available, but. So proBNP, over 100, elevated risk, over 300, very high risk. All right, so both sides, the risk modifier group and the elevated risk and MACE group said, look at the EKG if, who do you get the EKG on? So if the patient's coming for elevated risk surgery, so not an endo, right? You don't need an EKG with endo. Why? Because you're gonna go in the room and put them on a 3-lead EKG, and that's gonna give you what you need for low risk surgery. It's gonna give you rhythm and rate, right? You're gonna see if it's sinus or AFib, you're gonna see if it's rapid or not, and you're gonna be able to make the decisions you need there. But for elevated risk surgery, you ask yourself, if they have known so who do you order that EKG? So the nurse says, do I need an EKG on this patient? They're in the holding area, so do I need EKG? So known CAD, arrhythmia, peripheral artery disease, cerebrovascular disease. Why cerebrovascular disease? Because vascular disease is a systemic problem. So Cleveland Clinic years ago took 1,000 patients for major vascular surgery. Only 1 in 10 had normal coronary. So if you have strokes and stuff, you probably have vascular disease in your coronaries. For some reason, it spares Lima though. I don't know why. All right, so get EKG on people you suspect have disease. Is that fair? Now, this was new too. If there's new abnormalities, obtain further evaluation. And I was like, oh, this is going to be a problem. Because when's the last time you saw a normal EKG on one of our patients, on a Benoit patient, right? Not too often. So basically, this is the stuff you should be looking for. Like, ST depression is very sensitive for ischemia, like very specific for ischemia. If it's not a refill abnormality. So, you know, and I know in our ORs we have ST mapping, you can trend them through the case, but if you have your EKG and they see these things, you might want to talk it out with the team. And who is the team? It might be your attending. It doesn't have to be a medicine person or a cardiologist, but you're just trying to get like a team-based approach. All right, who gets an echo? So you're doing your PAT, your pre-op, and do we need an echo or not? This is like every hip fracture. What do we do with them? Do we get an echo? Do we not get an echo? So this is their recommendation here. So new dyspnea, I guess I talked about this, but new dyspnea, physical exam findings of heart failure, and this is like, this is in our lane. This is our wheelhouse. Like you need to you need to look. You know, put your finger pretibially, push on their liver, lay them flat, talk to them, listen to the basis. There's rails all over the place. Maybe it's fluid. So if there's new dyspnea, findings of heart failure. And why is that important? Because the heart failure is where the risk is. So we want to know those patients so we can talk to them about risk and manage them as if there's increased risk. And suspected new or worsening LV dysfunction. So if yes to those questions, and they have a known diagnosis of heart failure, preoperative assessment of LV function is reasonable. If they don't have a known diagnosis, preoperative assessment of LV function is recommended. Class 1, ooh, we haven't seen a class 1 in here yet, so they're really pushing for that. So let's commit that to memory. Now the right side of the heart dysfunction is really associated with poor outcomes, but they don't want you screening everyone for RV dysfunction, but patients that you think might have it, you want to screen. You know, I sent this to you through the WhatsApp. This is like the slides that I don't have time to talk about that you should really read through. I wanted to talk about coronary CT angios, coronary CTAs. I'm not recommending you order them ever, but if they're in the chart, you want to, if the score's 0, like they're good. Like there's not obstructive coronary disease. And so a primary may order it in a patient who's going for elevated risk non-cardiac surgery as a screening tool. And the result you can interpret, but you know, I'm not saying like suggest it or order it, but it's something you may see, and that's why they put it in here. So who's it recommended for? Someone who has elevated risk with the screening tool, the surgical risk is high, and they have poor functional capacity. It could be used as a screening tool. Stress testing, they really want poor functional status. They're going high risk surgery, and they have elevated risk of perioperative events, right? So they can't go up the stairs. It's big time surgery, and their risk of MACE is high. Then they can be considered. But it's not, oh, you're having a total knee, you need to echo and stress. That is the wrong way to go, because people will have a positive stress. They'll get a cath, which has a 1% risk of stroke, and they'll stent the distal diag, and it will not improve their outcome. So it'll put them at risk, but their outcome will not improve. because the low pre-test probability. All right, and then you're having ACS, you're getting a cath, but other than that, the patients who they recommended are people who have chronic coronary disease with maximum medical therapy with still symptoms, and then let's say you get a stress and there's a big area of perfusion defect, then that person should get a cath. All right, so the CARP trial, it's not good to memorize a million studies, but there are a few that are going to come up over and over, like POISE trial, for beta blockers. The CARP trial is for should you go get your coronaries fixed before surgery. So they took two groups with positive stress, and they did an intervention on one, and they did maximum medical therapy on the other, and both groups did just as well. So stenting the distal diag in this prospective randomized trial did not improve outcome. But who was excluded? Because remember, when you look at a study, is it your patient in front of you? Excluded were left main disease. And left main is also left main equivalent. So they have an LAD and a CERC, left main equivalent. In other words, very positive stress test. And EF less than 30 were excluded. So it doesn't necessarily apply to those patients, but for all comers, just going and saying, oh, you're having a lumpectomy, your stress test is positive, you need to be stented, or I'm not doing this case. That's not the answer based on the CARP trial. But at the same time, we got to take this stuff seriously. So if your patient, how many times have you read a patient had an MI in the problem list, all the time? That patient is at a 3.5 times risk of MACE. And this one even was more profound to me, that how many patients have a stent within 2 years? All the time. They're twice the risk of MACE. So we say, oh, he's fixed. We're good. He had his stent. No, he's 2 times the risk of all comers. I guess it makes sense. It means they have disease, right? But I think a lot of times I have thought, well, he's fixed, let's go ahead. But it may have not been the culprit lesion. It may suggest he has more disease in other places. And so we want to be good anesthesiologists. It's like the subtle outcomes that we can make a difference in that nobody recognizes. But if you do a good job, you can make a difference by not having post-intubation hypertension and tachycardia, or shivering patient in the PACI, or patient in pain all night. I've seen a bunch of spine patients have MIs post-op day 2, and I look through the chart, and the night before they were in pain all night long, severe pain. What do you think your MBO2 is if you're in agony and you have a widowmaker in your left main? So if we do a good job, we can make a difference. And no one may recognize that it's because of us that they did well, because it's subtle, but we can make a difference. All right, so what time are we looking at? Optimal timing of elective or time-sensitive non-cardiac surgery for prior PCI requiring management of DAPT. So bare metal stents, you need to be on DAPT for a month, and then it re-endothelializes. Drug-eluting stents, sirolimus, paclitaxel, they don't re-endothelialize, so they need dual antiplatelet therapy for a longer period of time, because your platelets will see metal and make a clot, and you'll have in-stent thrombosis, which carries an 80% mortality. So we have to be on DAPT. So how long do you have to be on DAPT? So if you let's say you need surgery in a week and they need to do a cath because you're symptomatic, they may choose to just balloon it because you only have to wait 2 weeks. If they know you need surgery that's going to cause bleeding, meaning you have to stop the DAPT, because you could just do the surgery on the DAPT. But if you have to stop the DAPT and they know that, they may do a bare metal stent. What's the problem with a bare metal stent is they re-stenose because the endothelium builds up, and it's a 1 in 5 chance at the end of the first year. With the old technology, it's probably better now. But if it's a drug-eluting stent in the setting of acute coronary syndrome, they need to be on that DAPT for a year. Unless, the benefits outweigh the risk. So if you say, yeah, I know they're supposed to be on a year, but we really have to do this cancer surgery, like a Whipple or something, they can't really be on Plavix and aspirin for the Whipple. I mean, maybe the surgeon will agree to it, maybe not. But you could consider after 3 months stopping the Plavix, but it's not ideal. So in the setting of chronic coronary disease, you want to wait 6 months. In the setting of acute coronary syndrome, you want to wait 12 months. But if you have to go to surgery and it has to be stopped, you can consider stopping it after 3 months if the benefits outweigh the risk. Or continue the aspirin. That's a new, very clear statement. It's not new actually, it's always been around, but they're like, continue the aspirin. 75 milligram aspirin should be continued in your PCI patients for surgery, if it's okay with the surgeon, but you can tell the surgeon that in our big observational studies, there is an increased risk of bleeding. There is not increased risk of bleeding. So you may have a few surgeons that are saying, well, I'm working on the retina, I really can't have any bleeding, we have to stop it. Or I'm working in the in the head and on a dural sinus tear, and I really can't have them on any anticoagulant. But in general, doing orthopedic, whatever, the data is pretty clear that they can continue baby aspirin. All right, and that's what this slide is. This says like it should be a discussion with the team. And patients on antiplatelet, post-PCI, in patients with prior PCI undergoing non-cardiac surgery, it's recommended to continue aspirin if possible. And then that's class 1. And the second statement is in patients with CAD who require time-sensitive non-cardiac surgery within 30 days of PCI or less than 3 months of DES, you want to continue the dual platelet, which is what we just talked about. Now, the other week, a cardiologist stopped Plavix, admitted the patient, and put them on Integralin or Riopro, which are 2B3A inhibitors. And that's because that cardiologist felt that that patient was at a very high in-stent thrombosis risk. So you may, from time to time, see a patient get bridged for PCI history. And that's because the surgeon knew that that patient had a stent at a bifurcation, or was stent back-to-back, or an undersized stent, or disease that wasn't fully fixed. And so we defer to them, but if you see that, that's why that happens sometimes. Okay, if you're on antiplatelet drugs without prior PCI, a patient with chronic coronary disease without PCI undergoing elective surgery, it may be reasonable to continue aspirin. So this is, they don't have a stent, but they're known to have coronary disease, so that would be like a perfect, it's not really primary prevention in a way because they have disease already, but it's reasonable to continue that. And then there's no benefit in patients with CAD without PCI. Okay, so patients undergoing elective non-carotid surgery routine ASA. So just like saying you need aspirin for all comers, not is class 3. All right, oral anticoagulants, so your Pradaxa and all those guys, they're saying that like low thrombosis risk patients don't need to be bridged, and higher risk thrombosis patients should be bridged. And so that's going to be a multidisciplinary decision, not made by us. Beta blockade is something that there's been a little bit of a pendulum. There was a time when people said the number one determinant of myocardial oxygen consumption is heart rate. We should beta block everyone and there'll never be another heart attack. So they studied that. They gave, in the POISE trial, toprol, like 100 to all comers, and more people died because they had strokes. Because when your pressure is low, your body's supposed to raise it. And if we iatrogenically block that, you have a stroke. There were less heart attacks, but all-cause mortality was higher because of stroke, so that is no longer a recommendation. But if you need a beta blocker for your coronary disease and you're on it, you should continue it. So another one, we don't see many ones. If they're on it, they should take it on day of surgery, because if they don't, they will withdraw from it. Their heart rate will go up a few beats, and their contractility will go up a little bit at a higher rate, and they will use more oxygen. So there's 2B evidence that if patients are planned for elective surgery, so they go to the pre-op doctor for a clearance, and there is a new indication for beta blockade, it may be reasonable to start it, but you try not to do it the day of. You try to let the body get used to it and get a new volume status and figure things out. And you still may use it intraoperatively once you determine, okay, the patient's euvolemic, they are adequately anesthetized, they have enough O2 content, and their heart rate's still high. Maybe they're a little high thyroid or something. Maybe you'll titrate a milligram of metoprolol at a time to improve their their O2 consumption versus supply ratio. But we don't just say heart rate's 110, give beta blocker. First we say, are they euvolemic? Are they deep enough? Are there other factors going on here? And then maybe we'll titrate it. But if the body's screaming for help and like heart rate's 130 because they have gram-negative sepsis and we block that, we increase the risk of stroke. That's been shown. Statins are like incredible for stabilizing plaque. They 100% should take their statin. And if they're at risk for, or you think they have underlying vascular disease, it should be started. Not canceled so you can start it, but statins seem to be a no-brainer. ACE inhibitors and ARBs were addressed. So cardiologists love them. We don't like them because we have the low blood pressure, but they love the afterload effects on the heart. So they met in the middle and they said, if for heart failure patients, it might be reasonable to continue them in the perioperative period for afterload reduction to allow forward flow. And 2B, so not 2A, 2B evidence that in patients with controlled blood pressure undergoing elevated risk non-cardiac surgery on ACEs or ARBs, holding 24 hours prior to surgery may be beneficial to prevent hypotension. So if you're going to be doing a beach chair shoulder, they should hold it. If you're doing a colonoscopy, they should take it because that's not elevated risk versus a situation where you want to maintain cerebral blood flow. It's going to be a judgment call. There's going to be controversy with this one. Every once in a while, you'll hold it and the patient will come in and the pressure will be 200 and you'll kick yourself. Why did I do that? So I look at the type of surgery. Are we going to be beach chair or not? Are we going to be, long surgery or not? A lot of times I'll tell them to bring it with them and we can decide to give it to them orally in the morning if they're running high. Sometimes we'll titrate a little something intravenously because we can get them back under control. But what you don't want is patient to hold it, pressure's 210, their case is delayed till 2 p.m., and then they have an NSTMI in the afternoon when they came just for a cataract. That happened to me. So patient held it, pressure was 210 all day, case got postponed. She was super anxious the whole day, and she had troponins positive. She had an MI because her afterload was so high, her wall stress was so high that she was not able to deliver enough oxygen and she infarcted. It is not evidence-based to start clonidine perioperatively for better outcomes. All right, sugars. I thought this was cool. They address things like anemia and sugar in this cardiac paper, but they say, if you're talking to a surgeon, they've got a patient coming, say, make sure there's an A1C so we know that they're under control. So if there's no A1C within 3 months, it's reasonable to get it. This is not you're going to cancel if it's not there, but it's part of your perioperative assessment. Anyone know what an SGLT2 drug is? Trisha? Yeah. So we're going to have to change this as a department. We are going to have patients hold their SGLT2 drugs 3 to 4 days before surgery because it puts them at a risk for euglycemic DKA. So normal sugar, but they're acidotic, it's DKA, it's from the drug. They're universally recommended to be held for 4 days before elevated risk non-cardiac surgery. And we currently don't have that as policy, so we'll have to fix that. And then this is new. It's reasonable to continue the metformin. They used to say to hold the metformin for 3 days to prevent anaerobic glycolysis. Forget why, about gluconeogenesis in the liver, but now it's reasonable to continue it. All right, pacemakers. So they got a new algorithm here. So you have a pacemaker or a defibrillator. Surgery is above the belly button. I'm sorry, below the belly button. What does it say, above? Okay. If there's EMI above the umbilicus, if there's not, don't worry about the pacemaker. Isn't that so helpful? If it's a hip surgery, if it's a knee surgery, if it's an ankle surgery, don't worry about EMI. This is for transvenous pacemakers. There's now these sub-Q things, and that's going to be another discussion. But if you're below the belly button, don't worry about EMI. So basically, the pacemaker is sensing and then firing based on what it senses. If there's EMI, it can't sense and it doesn't know to pace. But if you're below the belly button, there's not going to be EMI. Try to put the grounding pad distal. Return pad, it's not grounding pad. Okay, so if it is above the belly button, so you're working on the gallbladder, the right ventricle is right here, right? So that's very close. You're working on the transverse colon, the heart is right here. You're doing an AV fistula, you're close. So if that happens, you ask yourself, is it a pacemaker? If it's a pacemaker and they're pacemaker dependent and there's going to be EMI, the pacemaker should be reprogrammed by a rep to asynchronous mode. I'm sorry, that's for defibrillator who's dependent. So pacemakers with a magnet will go to DOO or AOO or DOO. They'll just go to asynchronous mode. They'll just pace with a magnet. A defibrillator, the magnet will turn off anti-tachyarrhythmic functions, but it will not go to DOO, VOO, or AOO. So if you are dependent with a defibrillator, the magnet will not make the patient pace. It will just turn off the shockable therapies. So if there's going to be continuous cautery on a big lesion in the liver, and the patient's dependent, that patient should be reprogrammed preoperatively. If the surgeon is going to give you EMI. If the surgeon says, I can use bipolar, you don't have to worry. Because bipolar is current between the two ends of the instrument and it does not cause EMI. Or if the surgeon can do short bursts of cautery, you do not have to worry because they'll only lose their heartbeat for short periods of time. But if there's going to be continuous cautery of a tumor bed above the umbilicus and they're dependent and it's a defibrillator, they should be reprogrammed. So that's a unique situation. So, but if it's a pacemaker, the magnet will go to DOO. So, do you have to put the magnet on right away? No. But maybe before induction, you put it on to make sure that it is, certain people work around electrical fields like on high wires or in MRI suites and they have their magnet functions turned off. So you want to put it on, make sure it goes to DOO, take it off, and then let them do the case. They may cauterize and you see your pulse ox going normal, you don't need to put the magnet on. But if every time they cauterize, the pulse ox goes flat, you put the magnet on for that period of time. Fair enough. Unipolar cautery causes EMI above the umbilicus. Bipolar don't, no magnet. Yeah. They don't like it. It's like a dirtier cautery. It's not as like a pencil. It's like a marker. And so they will tell you I can't use bipolar in certain situations. But yeah, I've had surgeons use it.
Yeah.
All right, we got to wrap up. So hypertension, I thought this was cool. They actually gave a number. Who likes numbers? So this is not an absolute. You will not cancel every case who is 182 over 110. This is saying if the patient is poorly controlled preoperatively and they're coming for elevated risk surgery and they're poorly controlled in the holding area, you can have that discussion about postponing. My case yesterday, she was 190 in the holding area, but in the cardiologist's office, she was 120, and in the primary care office, she was 138. That's a different patient who's 190 in all three places. Because she was having a replacement, so it wasn't small surgery. But she's normally controlled, but she's so scared today that we're going to cut her shoulder out and put a new one in. So after 2 of her sets, she was 147, and I was very comfortable proceeding. But 190, 190, 190, gotta have a talk. Your beach chair, it's not ideal. All right, so elevated risk non-cardiac surgery, poorly controlled preoperatively, 180 over 110, which is severe hypertension. Maybe have the discussion about getting them optimized, bringing them back when their cerebral autoregulatory curves, kidney autoregulatory curve, coronary autoregulatory curves are improved. In the OR, obvious stuff. Post-op, don't forget about them post-op. Strokes, you want to wait 3 months for elective non-elevated risk non-cardiac surgery. Pretty clear outcome data there. AFib, so You notice new onset AFib right before colonoscopy. Should you cancel it? Patient prep, took off work, family's there. Probably not, it's a judgment call. But remember, after cardioversion, the risk of stroke is highest for that next whole month. So it might be better to get their intervention done before that. The key thing in this paper is don't just send them on their way. They also talk about you have AFib during your case, it gets better, goes back to sinus. You got to flag that patient to the cardiologist. They may want to anticoagulate them in the long term if their CHAD score is high enough. So you say, oh, they're back to sinus, let's send them home. They go home and have a stroke 8 months later. A little bit on us. So, if the rate's elevated, you want to fix the rate. You want to plug them into post-op anticoagulation. You want to do a good exam and history and make sure it's not ischemic, right? Because there's lots of AFib. There's lone AFib, there's holiday heart, there's ischemic. Ischemic one, you may not want to get into a hip replacement with new onset AFib. New onset AFib for a hip replacement, that one might get postponed. That's a little bit of a bigger deal. But colonoscopy, even like a lumpectomy or something, I might proceed. It's going to be a judgment call. All right, heart failure, pretty stuff we're eating the ground. TE, you can't figure out the hypotension. TE is where you're at. You got mitral stenosis. TE is probably a good idea. PA catheter, same thing, like mixed shock states. You can't figure it out, but putting it in for your Whipple because it's a Whipple, that's the wrong decision. But your pressure's low, you don't know what's going on. Those are, or cardiac cases, obviously. David Sessler, our temperature guru, says you have 30% increased risk of wound infection if you're 1 degree cooler when you hit the PACU. So there really is push for MH screening and for wound infection to temperature monitor. They basically talk about TXA for any case where you're going to lose a lot of blood. So I thought this was interesting because in the past, we focus on ortho or OB, but they're saying if it's a bloody case, consider TXA. Cases over 3 hours, maybe you want to run a drip, like it's an 8-hour SCOLI or something. Maybe you want to do, milligram per kilo per hour, something like that, or redose. Too much is not better either. In the OB literature, 2-gram study had more PE, so I don't know. But certainly 10 per kilo, ideal body weight, up 2 grams. Like the ortho literature is like a gram for all comers, so that's fine. You don't have to be like, oh, there's 70 kilos, I need to give 700. I would be comfortable giving a gram, but once you get like a 45 kilo person, you might cut back a little bit. And then pre-op iron, and I noticed Domi does this. You got a DUB patient whose hemoglobin is 7, they should be on iron for some weeks before surgery if possible. All right. The other day, Scheinkraut was starting a hip and sugar was 400 and he told me she'll be fine. But if I tell her that, if I tell him that glucose above 200 is associated with a 2 times higher all-cause mortality, now 4-fold higher cardiovascular mortality, that might have a bigger impact than me just saying, no, she won't. And they talk about, A1C's over 8, you might want to consider rescheduling. I'm not telling you to cancel at A1C at 9. I'm telling you to talk to the surgeon and the patient because there is a case where a guy got a penile prosthesis with an A1C of 14 or 15, got infected, needed amputation, sued the anesthesiologist. And I thought maybe that's a surgeon's decision to proceed or not, but it's weird, like putting them to sleep, saying they're medically optimized, and the anesthesiologist went down with the ship. So you want to document, if you see an A1C of 12 for an ortho case, you want to document that you had a risk-benefit discussion with the surgeon and the patient, and they're willing to proceed because they may have a 6-fold higher risk of wound infection. MINS, myocardial injury after non-cardiac surgery. So you may have a high-risk patient check a troponin 24 and 48 hours later, and if it's a little elevated, it's not that they have to go to the cath lab, but they need to be looked at further, maybe even as an outpatient. So in other words, we're able to determine who may have underlying cardiac disease if there is MINS. Now there's type 1 and type 2 SCMIs, and it's a little bit out of my league, but obviously if you have plaque rupture and your troponin is off the charts, they're going to go to the cath lab versus rate-related ischemia, they're gonna get treated medically, versus just MINS, they might get worked up as an outpatient. But the bottom line is, you may choose to survey certain patients in the post-op period, and now you'll know a little more about why they're doing that, what that means. So I want you guys to work through this when you're bored on call. This goes through each cardiac lesion and what the data is, and who needs an AVR before surgery, who needs a balloon valvuloplasty, who should not get one. Like for example, if you're asymptomatic, moderate severe aortic stenosis, you're asymptomatic and your LV is good, it might be reasonable to proceed, versus someone with poor LV, it may be reasonable to do an intervention, versus a symptomatic patient who should get an intervention before elevated risk non-cardiac surgery. It goes through MR and how that's a pretty well tolerated lesion until the LV dilates really bad, and how MS is not so lovely under anesthesia and involves higher levels of monitoring. Talks about like pre-capillary pulmonary hypertension and how inhaled nitric oxide might be an option. So if you're not comfortable with that, you might want to pull in a cardiac anesthesiologist. Say, listen, I have a big case on severe pulmonary hypertension patient. I don't really know how to use nitric. Maybe you can be involved in this case and the planning around it. Or maybe a patient goes to a center that deals with that if you're at a community place. So you're at a community place, they want to do a big thing, pulmonary pressure is 90. I don't think this is right for you. That might be your job to say for elective case, semi-elective case. Sometimes a valvulus valve comes in and PA pressure is 100 and you are stuck. But if it's a planned surgery, cancer surgery, you may have to go to a bigger center. And I don't mean here, I mean if you were at a community place. Hypertrophic cardiomyopathy talks about maintaining eubulimia and using alpha agonists, and these patients do well if you know how to manage them. This is that congenital heart, like low, intermediate, high risk, so you can move through that and say, who is on the risk modifier category and who isn't. All right, that's it. Any questions?